Hi, my name is Lisa Rezende, and I'm the Director of Education at Force, Facing Our Risk of Cancer Empowered. And we are pleased to have our first of our live Google Hangouts here at breastcanceranswers.com. And I have joining me Jana Pruski-Clark of InformedDNA Genetics. And today we're going to talk about hereditary breast and ovarian cancer. Force is the only national organization dedicated to all individuals and families who face hereditary breast and ovarian cancer. And we thought for our first hangout, it would be a good idea to sort of talk about what it is. So I'd like to introduce Jana. Hi, Jana.
Hi, thank you for having me.
And why don't we get started and talk a little bit, how do we know if a breast cancer is hereditary?
I think that's the perfect place to start. And I always like to back it up a little bit and talk about hereditary cancers in general. Where I start with, I'm a genetic counselor, so, where I start with anyone who has an appointment with me is simply by explaining first and foremost that most cancer is not hereditary. Most cancer does not run in the family. Most cancer is not due, to an abnormal gene that's been inherited from one side of the family or the other. If we look at all cancer types combined together, about 10% of all cancer is considered hereditary, and that number would apply to breast cancer as well. Hereditary cancer, as a general explanation, those are the result of a gene with an abnormality that has been inherited from one parent or the other. We call those abnormalities mutations. They're passed through the generations of a family, and they increase the risk for very specific cancer types. They do not increase the risk for every type of cancer, but they increase the risk for specific types of cancers within a family. I think for most of us, for hereditary breast and ovarian cancer, the most common genes that we're mostly familiar with are the BRCA1 and BRCA2 genes. That stands for breast cancer 1 and breast cancer 2. The primary cancers we see in families with a BRCA1 or BRCA2 mutation are breast and ovarian cancer. The breast cancer tends to be premenopausal, meaning it tends to happen at a younger than average age. We can also see some other cancer types, including pancreatic cancer, melanoma, prostate cancer, male breast cancer is another example. When we're thinking about genetic testing, though, one of the things I always like to explain is that a lot of times I hear people who say to me, I have the breast cancer gene, or I have BRCA1. And I think it's important to note that we all have BRCA1 and we all have BRCA2. We actually have 2 copies of each of them. It's not the genes that are actually the problem. Those genes, when functioning correctly, provide a very protective and helpful effect. What is the problem is if someone inherits a mutation or a change in the DNA level of the gene that prevents it from working correctly. That's what genetic testing is looking for. So not really looking to see if you have the gene or not, but looking to see if that gene is functioning correctly by looking to see if you carry a mutation in it.
I think that's a great point to think about, because I think that terminology really can be confusing to a lot of people.
Yeah.
I think the other piece that comes in here is the breast and ovarian cancer. So if we're here talking to a breast cancer audience and maybe somebody's already had breast cancer, how does the ovarian cancer fit in there? If they're thinking about testing, should they be thinking about ovarian cancer? Does it have to be in their family already, or is just having a mutation enough to put you at risk?
So having a mutation is enough to put you at risk. We know that mutations in either BRCA1 or BRCA2 increase the risk for both breast cancer and ovarian cancer. So it's not, one increases the risk for breast and the other increases the risk for ovarian. They both increase the risk for both types of cancer. And I think that that's a good point that you make, Lisa. A lot of women come to me with questions about how this may impact their surgical decision-making, for example, of a current breast cancer diagnosis. But we also really have to look out long-term, thinking about how this impacts other cancer risks, not just the short-term decision-making that may be happening right then.
And yes, I think that, and how would it impact, even if we're looking at short term, if somebody's making a surgical decision, would it be to their benefit to pursue testing before they make these decisions?
Yeah, that's oftentimes when a lot of people start hearing about BRCA1 and BRCA2 testing is in the immediate time frame right after their diagnosis. A breast surgeon may bring it up as an option to think about surgical decision making. And the reason that comes up then as a more immediate, testing process and more immediate decision is because a woman with a BRCA mutation is at increased risk to develop a second primary breast cancer in her lifetime. So it doesn't necessarily impact the risk of recurrence or the risk of metastasis, but it impacts the risk to develop another unrelated new breast cancer in the future. So because of that, when a woman is considering her surgical options, she may choose to have a larger surgery than needed to treat her breast cancer. For example, if a lumpectomy is needed to treat the current breast cancer diagnosis, we talk with women about the option of a bilateral mastectomy for not just treatment purposes, but also prophylaxis or prevention purposes as well.
And the reason you're thinking about prevention is, does having this mutation, is that going to increase the risk for that second primary cancer, correct?
Correct.
Now, what if you have been treated for breast cancer, say 5 years ago, 8 years ago? Is it, and you start realizing that there is a pattern in your family? Maybe you found out there's some aunts that had it that you were unaware of, or it's coming down from your father's side. Is it still an option to pursue testing at that point?
It's absolutely still an option to pursue testing at that point. There may be additional management options that you're not currently pursuing based on your previous diagnosis alone. And I think the ovarian cancer example that you mentioned earlier is a very good example of that. A woman who has a breast cancer diagnosis may not realize that she is at increased risk to develop an ovarian cancer if she is BRCA positive. She also may make different decisions, for screening purposes. For example, if she had a lumpectomy for her breast cancer diagnosis 5 years ago, she may want to think about additional screening options such as breast MRI for a future breast cancer, or she may want to consider going back and having additional surgery such as a bilateral mastectomy to reduce that risk. So it is still absolutely beneficial to that individual's medical management, 5 years down the road or however many years down the road. But there's also significant benefits to family members that many people think about in terms of considering testing later as well.
So when you're thinking about family, and maybe, like I said, you had breast cancer in the past and you didn't know if you were a candidate for testing, what are the types of cancers we're looking for in the family? I think it's easy to see if your mother and your grandmother, and it's been coming down the female line, but what are some maybe red flags if your mother never had breast cancer before, but yet you had breast cancer at a relatively young age?
Sure. There are very clear red flags in family histories that make genetic counseling an appropriate option. For example, as you said, any woman with a young breast cancer diagnosis is recommended to consider genetic counseling for further discussion. And we think of a younger than average diagnosis as being anyone diagnosed with breast cancer before or at or before the age of 50. We also would consider a woman who had breast cancer in both breasts or maybe two primary breast cancers in the same breast at any age as a candidate for genetic counseling. The other cancer types that we typically look for are ovarian cancer, in an individual or in the family, prostate cancer, pancreatic cancer, melanoma. When we're specifically thinking about BRCA1 and BRCA2, those are really the main cancer types that come to mind as red flags. Other components, though, that people should also be aware of, are the type of breast cancer that someone may have and their ethnic background. We know that triple-negative breast cancers, for example, are more commonly seen with BRCA1 mutations than they are seen in the general population. By far, not every triple-negative breast cancer is related to a BRCA1 mutation. The majority of triple-negative breast cancers are not related to a BRCA1 mutation. But having a triple-negative breast cancer diagnosis alone is enough to warrant referral for genetic counseling to discuss if that testing is indicated. And just to clarify, by triple negative, I mean estrogen receptor negative, ER negative, progesterone receptor negative, PR negative, and HER2/neu negative. When all of those are negative, we call that triple negative breast cancer. And again, those are more commonly seen if a woman has a BRCA1 mutation. She is more likely to develop a triple negative breast cancer.
And if you did have a triple negative breast cancer, is that something your oncologist would have told you? Is that information that most people commonly have?
You know, most people that I talk to during a genetic counseling session are very aware of the hormone status of their breast cancer diagnosis, primarily because it relates to the decision of whether or not someone should take medications like tamoxifen after their treatment is complete, or whether they should receive treatment including Herceptin at the time of their diagnosis. So many people are aware of it. If you're not aware of it, I think it is absolutely something that is worth calling and getting the pathology report or asking your doctor's office for that information. When you're looking at your pathology report, it is almost always that I have seen included on there if it was run. Sometimes for cancers diagnosed many, many years ago, the HER2/neu, for example, may not have been run as it wasn't available then. But most of the time, you know, for more recent, this is something that is standardly run on a breast cancer diagnosis.
Excellent. So let's say you've decided to pursue testing and you come back and you do not have mutations in BRCA1 and BRCA2, and this was 5-8 years ago, and you're sure there's a lot of cancer in your family. Are there other options now? Are there other types of testing available?
Absolutely. There are actually quite a few options that I would encourage someone to meet with a genetics expert and discuss in that situation to determine if they're appropriate for them. I will give you a few examples of the options that I would talk to someone about in that scenario to help provide a little bit of guidance. But yes, genetic testing has changed quite dramatically in the last 10 years and, you know, continuing to change. It feels like month to month, you know, as we go forward into the future with options that we have available. I think the most common change that occurred within almost 10 years ago, which many people are often aware of, is the additional testing that became available for BRCA1 and BRCA2. Many people know this as the BART test. It's a deletion, duplication, or rearrangement analysis or test of the same two genes. So it's still looking at BRCA1, it's still looking at BRCA2, but it's using a different type of technology in the lab to analyze them. And that additional testing can detect a very small amount of mutations that would have been missed by the standard testing that was done 9, 10 plus years ago. If someone has had negative testing, you know, BRCA1 and 2 testing before that was available, or they had testing done when it was not, you know, it was not run at the same time, that is absolutely something that can be added on. I typically quote, you know, a less than 1% likelihood of finding something abnormal by doing that additional testing. But national guidelines do now recommend, and they have for the past few years, recommend the inclusion of that deletion, duplication, rearrangement. Again, BART testing, as many people know it. They do recommend the inclusion of that in all BRCA1 and 2 testing. A genetic counselor can very easily look at your previous BRCA test results and tell you whether or not that was done. And if not, that's something that I would always recommend to anyone who meets criteria for BRCA testing that it wasn't done. It's always something I recommend that you go back, you know, and think about considering doing as well.
Wonderful. The other group that I think sometimes we're not always thinking about is men from families with BRCA mutations, or men with hereditary breast and ovarian cancer in their family. What are the advantages for men to test or pursue genetic counseling?
Yeah, I think well, that's actually a very good clarification when you said that genetic counseling does not equal genetic testing. So that's a very good clarification. Genetic counseling is the process where we discuss the family history and we talk about the risks and associated options based on that family history. But having genetic counseling does not necessarily mean that someone will meet criteria for genetic testing, and it does not commit anyone to having genetic testing. So I'm glad you said that. That's a good clarification. For men, obviously the options are very different. When we think about BRCA1 and BRCA2, the primary cancer risks that we are concerned about are breast cancer in females and ovarian cancer. But there are risks for cancer types that can impact men, including some that I've mentioned before, the pancreatic cancer, prostate cancer, and melanoma. There is also an increase in the risk for male breast cancer in men with a BRCA mutation. That risk is still quite low. It's up to about 6%, so it's actually even lower than the risk for a woman in the general population to develop breast cancer. But I think the most significant difference is that men are typically not at all aware of the breast cancer risk they may carry. And men don't usually learn how to do breast self-exams the way that we do, in our late teens and early 20s. Men don't typically have a breast exam as a part of, a yearly or whatever frequency they may have for a physical exam. And certainly most men are not recommended to have mammograms. And, for someone with a man with a BRCA mutation would be recommended to do breast self-exams, or at least be aware of any changes in that area, to have clinical breast exams by a doctor's office. And some men are recommended to consider mammograms sometimes. And for the other cancer types, such as prostate cancer, that may indicate that some earlier than average screening is needed, or it may indicate that additional types of screening that are not done in the general population are appropriate. I can also tell you from my experience in working with men who are concerned about their BRCA mutation risk, that also, again, one of their main concerns is for family planning and thinking about their own children and their grandchildren, and concern also about other family members as well.
Excellent. I think the family point is really critical to bring in there for everybody who's thinking about this. So if you all have decided to pursue genetic counseling, could you sort of walk us through what a typical session would look like and how one could find a genetic counselor?
Sure. I'd be happy to. A genetic counseling session, I always say to everyone, it shouldn't be a scary process. It really is a communication process. It's a lot of talking. It's a lot of information giving and a lot of information sharing. It's, for me, it typically, when you think about an initial genetic counseling appointment, before you actually come in and sit down with your genetic counselor, you would usually be asked to complete some information about your family history. So I always encourage everyone, do a little digging, after you've made that appointment or before you do, to get the most accurate family history information that you can. The recommendations we give to you are only as good as the information you give to me. So doing a little digging ahead of time, the types of things that I'm going to ask about are: how old did people live to be? Were they diagnosed with any cancer types? If they were, what was the primary cancer? How old were they when they were diagnosed? I typically ask about precancerous findings, and I'm talking about all the way out to third-degree relatives. So third-degree relatives are your cousins, your first cousins, and your great-grandparents. So I'm going all the way out, aunts, uncles, great-grandparents, grandparents, and asking all those health history-related questions about them. So during the appointment, we would typically go over your pedigree, which is the word that we use to describe your family tree. We talk about what we see within your family tree and any of those red flags for hereditary cancer. We discuss whether or not someone may meet national guidelines for any genetic testing. And if they do, what are the benefits of that test for that individual and for that individual's family? What are the limitations of testing for that individual or their family? Will this test give them the information that they're actually looking for at this point in time? So we talked for quite a while about the genetic testing option and what it means and what it doesn't mean for an individual family. And then we really go through the process of how genetic testing works, how we contract, not contract, but how we submit to someone's insurance company to get that information in terms of coverage. Most insurance companies have criteria for when they will cover certain genetic testing. So we talk certainly about that. And from that point forward, it's typically a conversation about, now, how do we get this genetic testing started? Genetic testing is usually done either through a blood draw or a mouthwash sample. So sometimes, if you would like, your genetic counselor will go ahead and facilitate that while you are there. Other times, they may send some testing paperwork to your doctor's office to have that testing facilitated. But by no means, having a genetic counseling appointment or meeting criteria for this testing does not at all mean that someone has to move forward with it at that point. I certainly encourage many people to get the information and then just sit on it. Kind of tuck it away and give it really some thought. Is it what you were expecting to hear? Were there significant differences in what your genetic counselor said versus what your understanding had been previously? Would this make a difference to your medical care? Do you think it would change anything for you? How would you really use this information? That's more of a pre-test appointment. In a post-test appointment with a genetic counselor, we would go over your genetic testing results, talk about what they mean for you, talk about what they mean for your family, and then perform a complete risk assessment, based on the testing results, based on your personal history and your family history. Here are the specific cancer risks that we believe apply to you, and here are your options. Not necessarily all related to breast and ovarian cancer, but what other cancers are we seeing in the family as well?
Excellent. I think that ties into a question that we had come up from one of our viewers about age of testing, and she's specifically concerned about ovarian cancer. But is if you don't have cancer and you are interested in counseling and testing, what is a good age to start thinking about that?
So it obviously in many ways depends on the ages of diagnosis in your family, but in general, the recommendation is to consider genetic testing when it will make a difference in your medical management. So for BRCA1 and 2, we typically think of initiating different medical care in an unaffected woman who has a BRCA mutation at approximately the age of 25. So at the age of 25 is when we would really start thinking about incorporating additional screening options that would not be recommended for your average 25-year-old. On the lower end, just thinking about how early would we be willing to test. BRCA1 and 2 testing is not testing that is done in children, not testing that is done in minors. So in terms of a cutoff, really adulthood, meaning the age of 18, is really the youngest that we would typically consider genetic testing for these two genes. We don't want to take away the option of making this decision from a child, him or herself. And also at that point in time, it does not make a difference in pediatric care. So having that information doesn't do any benefit to that individual by having that testing earlier.
Excellent. And then when we are talking about ovarian cancer risk versus breast cancer risk, do those risks rise at the same age, or is it different ages when you start feeling like you're at a higher risk?
Yeah, we tend to see premenopausal breast cancer with BRCA1 and BRCA2 mutations. So we do know that those risks appear to increase at earlier ages as compared to the ovarian cancer, which in BRCA1 and 2 mutation carriers we can really see at almost any age. We don't see the same age effect that we do with the breast cancer risk. For example, thinking about medical management options, since someone had asked about timing, we typically think of breast management changing at about the age of 25 in a woman with a BRCA mutation, whereas we really start thinking about the ovaries a lot more in that same setting around the age of 35.
Excellent. Thank you. So if somebody is interested in testing and they, where is an easy way to find a genetic counselor?
Sure. Well, if you go to the FORCE website, facingourrisk.org, without question, you'll find so many great links there. But one of the links that they do have is one to find a genetic specialist. The other options that you could consider looking at to find a face-to-face local genetic counselor, you could go to the website for the National Society of Genetic Counselors, which is www.nsgc.org. Genetic counseling is also available by telephone through InformedDNA, and that website is InformedDNA.com.
Yeah, and we can also help you at the FORCE helpline.
Absolutely.
Is there anything else that you would like to add, Jana, today? Thank you so much.
I think the last thing I want to add that I think is important currently, and people may have questions about, so I certainly want to make sure that I bring it up, are the newer available options of cancer panel testing. More recently there was a lot of news about the gene PALB2, so I certainly don't want to ignore that and want to make sure we address it a little bit today. Panel testing is certainly a more recent development that we're seeing more commonly done and more commonly available, in commercial lab settings. So it is something that's out there. I think the limitations of panel testing right now are that there are no national guidelines for the use of them, and for most of the genes that are included on those panels, we don't really know what to do if someone tests positive for a mutation in one of those genes, because again, there are no national guidelines for how to manage someone in that context. However, if it's something that you are interested in, if it's something that is appropriate for your family because you have tested BRCA negative, or your family history is suggestive of more than one hereditary cancer syndrome, I would definitely encourage you to talk to a genetic counselor about the benefits of that testing, also about the limitations, determine if it's something that would be appropriate for you and for your family. And the same really applies to PALB2, which is the more recent news that came out this week and last week. PALB2 is a gene we've known about for a while. We had much more limited information. There was a new article that came out this week, or last week I should say, that talked much more about the breast cancer risk associated with it. And PALB2 is a gene that appears to increase the risk significantly for breast cancer and for pancreatic cancer. There are no national guidelines for testing for that gene either. But again, if you have a family history, I think it's always worth talking to your genetic counselor and really determining if that testing may be appropriate for you at this point as well.
Excellent. And we have a new article on PALB2 on the FORCE website as well, www.facingourrisk.org, if anybody's interested. When we talk about national guidelines for management, I don't know that I wonder if everybody understands where there is a difference between national guidelines for BRCA and not having one. What does that actually mean in the sort of day-to-day treatment of mutation carriers?
Sure, that's a great question. When I'm saying national guidelines, I'm more specifically often referring to guidelines developed by an organization called the National Comprehensive Cancer Network. We refer to them as the NCCN. And they have a website. Anyone can have access to their guidelines and to their publications. The NCCN is an organization of cancer experts, ranging from oncologists to radiologists to genetics experts, who really develop guidelines for the detection, the treatment, the prevention, including genetic testing for most cancer types. So there are NCCN guidelines for BRCA1 and BRCA2 testing. There are also NCCN guidelines for the use of the other more common, although less common than BRCA1 and 2, but some of the other more common breast cancer genes that we see with a very high penetrant cancer risk, such as those associated with Cowden syndrome or Li-Fraumeni syndrome. But those guidelines are available to help us determine when testing is going to be most useful for someone, and they also give us guidance as to if someone tests positive for a mutation in that gene, what do we do? What's the next step? What's the appropriate management? It becomes challenging when someone tests positive for a gene where those guidelines do not exist. We may know that there's an increased cancer risk, but there are no guidelines as to how we should be following that individual. And you don't want to be over active and you don't want to be underactive. You don't want to do something that's not indicated for you that may put you at some other risk, but you also don't want to be, under responsive to that. The NCCN guidelines do change on average of at least once a year. So we're hoping that as the guidelines get updated, that more information will be included about these new genes as it becomes available.
Thank you so much, Jana. I think we gave everybody a lot to think about in terms of what hereditary breast and ovarian cancer is and how they can get more information on it. And I really want to thank you for joining us for our first Hangout.
Thank you, Lisa.
And we hope that if anyone's looking for further information, that you will look to the FORCE website, contact our helpline, look for genetic counselors if you feel that this is appropriate for your family. And thank you so much.
Thank you.